Okay, friends, we are going to move forward. We are going to talk about the cardiovascular aspects in pediatric practice in case of trauma. And it is going to be presented by a speaker who I would like to invite with a huge pleasure to our stage. Doctor of Medical Sciences, the senior doctor in the Department of Intensive Care of Cardiovascular Diseases in Boston Pediatric Clinic, the co-director of the Program of Quality and Results and Outcomes in the Family Cardiovascular Center, and also the associate pediatric professor in Harvard Medical School. I do understand, friends, that these topics are extremely important, and those who were with us yesterday during the first day of summit, we were greeting our friends, we were greeting our colleagues, and we were given just great applause. So please, dear Kshitij, that's for you.
Thank you very much for inviting me here today. It is a great honor and a great privilege to be here with you. Over the last 2 to 3 days that I've been here, I have heard amazing stories from the front lines, and that has only grown my admiration for the Ukrainian people. And so I congratulate you on your resilience during this conflict. My area of expertise is in pediatric cardiovascular intensive care medicine. I practice medicine at Boston Children's Hospital in Boston, Massachusetts. It is the largest pediatric heart center in the United States. But in addition to being honored to be here, I am also sad as well, because if I am on this stage today, then that means children continue to be at risk during this conflict. And we have seen that not only in this region of the world, but also, as we've seen more recently, in others as well. And we know that the impact on children is more than just the injury that happens at the time of an explosion or of a blast, right? We know that in areas of conflict, children who have chronic illnesses, those that are born with defects, do not receive the care that they require. This map here is of Europe and shows us the number of children under the age of 5 that die who were born with a childhood structural defect or an illness. The darker the color, the higher the rate of death of children under 5. And what this map is showing us here today is that in areas that we currently are in, and in Eastern Europe, that rate is already at baseline higher. And that difference in rate will only continue to increase as this conflict goes on. We also know that there's an emotional burden for children, just like those that are coming back from the front line. It's difficult to quantify these emotional challenges. They're not only because of what they witness, but because of the changes in family dynamics. They lose their brother or sister. They lose their mother or father. A soldier comes back from the front line with emotional and mental health challenges, and that changes the dynamic for the family and changes it for the child as well. Just like those coming back from the front line, the most common diagnosis for children is post-traumatic stress disorder. And although I've come to learn that that name is not particularly accurate, because post means that that trauma is over. And we know that that is not the case, that this trauma is ongoing. And so for children, just like those at the front line, survival is just the beginning of their healing process. What I'm going to talk about for the rest of the time that I have with you is a few principles that I feel could be helpful for you to take back when you're caring for children, either in the front line as a front responder, either at a stabilization point, or you're bringing them back to a hospital for further care. I am fortunate this afternoon to be able to visit the largest children's hospital in Ukraine this afternoon. I'm very much looking forward to the great work that is being done there. So what are the most common types of injuries that you will see for children in a trauma setting or in conflict? The pattern is similar to that of adults: traumatic brain injury, burns, and blast injury. This is where we start to see differences between children and adults. As you may remember, when a child is born, their skull is not fully formed as it would be an adult, not full bone, doesn't protect as much as it would for you or for me. They are the open spaces that have not yet closed. In fact, it can take up to 2 days for that, 2 years rather, for that to happen. So that puts them at great risk for head injury when it does occur. For example, on these scans of brain images of children, you can see the real bright spots are abnormal areas of bleeding. What's also important with regards to children that they're higher risk for is that even though they have these spaces for which swelling can happen after a brain is injured, it can cause shifting in the structures of the brain. And so that most further right-hand image there shows actually what should be in the middle are those black spaces that are filled with spinal fluid, and it's all shifted to one side, right? These are specific things that happen more significantly in children. But despite the similarities and patterns of injury, the survival and complications for children differs. And why is that the case? So children's bodies mature differently, obviously, than adults. And in fact, a young child, a newborn, is even different than a young toddler child and is different than a teenage young adult. There are differences in the way the body responds to stress, and I'll share some of that with you here today. And that impacts the types of injuries and how severe that injuries will be for children. Children are much more susceptible to chest trauma. And this is important when you're responding to such an event. For you or for me, our ribs are already made fully of bone and provide a protective barrier for your heart and for your lungs. For children, when they're born, their ribs are still made of cartilage. And that continues to change into bones well into their teenage years. What that means is it does not provide as much a protective barrier as it would be for an adult. And so instead of protecting against force and then the ribs breaking that energy, the chest actually bends. And when the chest bends, that energy is directly transferred to the structures that are behind the rib cage, heart, and into the lungs. More direct injury in children that you may see with the same force in adults. Also, the structures within the chest of a child aren't as fixed in position as they are for an adult. So when that energy of high velocity comes and impacts a child's chest, those structures can move. And so, for example, that chest x-ray there on the right side of your screen, that is actually a collapsed lung because of extra air in the chest, and that heart is pushed all the way over to the left-hand side, right? And with that is not only direct injury to the lung and heart itself, but can also cause vessel tear and significant bleeding. So chest wall is structured differently, the direct force transfer is different, and things can move. Associated with injuries, we just heard about some of the chest trauma in adults as well. A third of them will have blood in the chest. A third of them will have air in the chest that shouldn't be where it's outside of the lungs. And about 10% will have both of these injuries. And you may see these injuries without any rib fractures at all, just because of the bending. So you could be fooled that there's nothing there, but in fact, there's significant injury behind the chest wall. What are some other key differences between children and adults? There's a higher metabolic rate. There's a larger body surface area to weight. This causes a lot of heat loss, cold stress. Think about responding to an environment where there may have been some disaster where a child is injured. They will lose heat and become a low body temperature fairly quickly. They have a larger head-to-body ratio. All of us know, especially those of us that are parents, like myself, your newborn baby has relatively a larger head, and as they get older, the ratio gets smaller. That puts them at higher risk for traumatic brain injury and direct sort of skull impact. This leads to low body temperature, hypothermia, and head trauma. They also have, at baseline, even the healthiest of children have a lower lung reserve. And what that means is that even before any injury to the heart or to the lungs, they are at high risk for low oxygen levels. If you're a first responder, a medic in the field, implementing oxygen early and quickly is very important in a child. There's significant differences between the heart of an adult and a child, and this is specifically my area of expertise. If we think about the way the body pumps blood out to provide oxygen to vital organs, it can do it in two ways. It either can make the heart pump more efficiently, just more blood goes out each time the heart pumps, or it can pump more quickly, right? For adults, our heart muscle is fairly efficient, right? It can squeeze harder, pump more blood out when it needs to. And so for us, our heart rate may be at 60 beats per minute or even less as we're sitting here. So our heart rate goes up when we exercise or when we're stressed, when we need more oxygen being delivered out to the body. A young child, especially in a newborn, that is not the case. The heart muscle is very inefficient, and so it has to pump harder even at rest. So although our heart rate may be 60 beats per minute as we sit here in this conference room, a newborn baby's heart rate is at 140 just at rest. And that slowly goes down as a child gets older. And so anything that lowers the heart rate of a child will significantly impact the ability of the body to deliver oxygen. What are two big reasons in this context that slows a heart rate down for a child? Cold temperature, traumatic brain injury, and secondary injuries. So we already know how important the heart rate is to providing adequate blood flow to the rest of the organs in a child, and they are at increased risk for things that will negatively impact that. The things to think about if you're an anesthesiologist, a first responder, these are principles that are helpful for you. There's things that are required for heart muscle to contract strongly. And so if you're there in the field or in an operating room with a child, think the need for calcium replacement, think the need for higher doses of adrenaline when you're using that, because that is what the child will need to maintain an adequate heart or cardiac output. Like for adults, a child's heart has to have enough volume to come back to pump blood out. In the context of trauma, such as what we're talking about here today, there are two main reasons why a heart would not get enough blood to come back out. One is bleeding. We heard about the importance of tourniquets yesterday with soldiers. The whole purpose of that is to prevent blood loss, to allow the heart to fill with blood and then pump blood to the rest of the vital organs that need it during times of stress. The other thing that will keep blood from coming back to the heart is high pressure within the chest. As the pressure in the chest gets higher, going from left to right, the blood that comes back to the heart gets lower with time. What are things that can increase the pressure in the chest? Air, blood, that same chest x-ray I showed before. So children are at increased risk for chest injury, increased risk for secondary injury to the heart and the lungs. All those things not only affect the lung and heart at the time of injury, but also impact the blood coming back to the heart, so a secondary issue, which is why it's important in children to evacuate that air, evacuate that blood very quickly and early in order to maintain an adequate blood pressure. We know that fluid can accumulate elsewhere in chest trauma for children as well. This is an echocardiogram, 4 chambers of the heart. This is abnormal fluid around the heart, where it shouldn't be. Keeps the heart from filling up. And you don't need sophisticated equipment to diagnose this. You may not have it at the front end of where you are, but certainly at a stabilization point. When I do work in Sub-Saharan Africa and do medical mission work there, we have a handheld probe and an iPhone. And we can use that to give us a quick diagnosis. So thinking about small miniaturized devices that can help you in the field, those are things to think about. This last principle I want to talk about is important as well. So we've talked about the differences in how the body matures, the impact of chest trauma and how that increases the risk for heart and lung injury, both primary and secondary. We've talked about the differences in the heart muscle and how it responds and how it can sort of to heart rate and how hard it can squeeze. This is a model of childhood hemorrhagic shock, blood loss. What I want to draw your attention to here is this middle line, which is blood pressure. As you lose more and more blood volume, bleeding, for example, in a limb injury, the blood pressure for a child can actually remain relatively normal for that child's age, even up to losing 30 to 40% of their circulating blood volume, right? Because they can compensate in other ways. For you or for me, an adult is way back here, 10 or 15% before our blood pressure starts to fall. So a child has more reserve in that way. But the other difference for a child is that they're okay before they're not, and it drops fairly quickly. So it's important for you to understand where you are on this curve. If you are here, you still have time to respond. If you are here, it could be a rapid decline of a child's health. And once you're down here, it's very difficult to rescue from that standpoint. The whole point of what we do in medicine, whether it's out in the field doing heart surgery, stabilizing a soldier with a tourniquet, is providing adequate oxygen to the rest of the body, right? And there are two big components of that. One is how much oxygen is being pumped out to the body. That is a reflection of red blood cells, oxygen that's dissolved in the blood. We just talked about the increased risk for children with bleeding in the chest. That would reduce this here. Blood transfusions early are very important. Fluid replacements very important early on. We already know with regards to oxygen that a child's lung function at baseline is lower than an adult. They have very little reserve. Oxygen therapy first and early is important. The other component of oxygen delivery is output. How much oxygen am I delivering out to the rest of the body? How much is the blood that's being pumped out from the heart? We just talked about how the heart is not as efficient in a child. It is much more important to maintain an adequate heart rate. So what are the things that impact that? Again, cold, secondary injuries, maintaining this up. In my mind, I always have this graph. And so whenever I have a child that is injured, specifically for chest trauma, as we're talking about here today, or is demonstrating signs of a low cardiac output state, I think about where I am on this graph and what do I need to do from that standpoint. So again, we've talked about sort of the differences in physiology, the differences in anatomy, and then my framework with regards to how I think about children's injuries. Again, children are not just small adults, and there are significant differences in with how we treat them and approach it. I put this back up here again and bolded my email here because I want to emphasize the point that I continue to want to be a resource for all of you here today. And if it's not something that I can help you with directly, I am happy to make connections to continue sort of this important effort that all of you are doing here today. Thank you very much for your time.
Дякуємо, друзі. Маємо хвилину. Я впевнений, хай ще побуде емейл. Обов'язково сфотографуємо, запишемо, занотуємо. Маємо
questions and answers. And also, please find a second to make a snapshot of the professor's email. But just to make sure that you can follow up on that later. But if you have an immediate question, then please go ahead. And also, please be reminded that we have reserved enough time during the coffee breaks and lunchtime so that you can do some networking and discuss whatever is the matter of your interest over a cup of coffee.